Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 45. We're going to wrap up our intestinal and urologic protozoa. We'll also talk about some of the blood and tissue protozoa, including malaria and also African sleeping sickness and others. Back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 45, Intestinal and Urologic Protozoa. This first table is a good review of some of the things we talked about in the last module, and it's important to remember. It's actually a great synopsis of what you can remember the clinically distinct diseases and organisms involved. We talked about Entamoeba histolytica, Giardia, Balantidium coli, Cryptosporidium, Isospora, and Trichomonas vaginalis. Plasmodium is a causative agent for malaria. There are more than 500,000 cases annually, and it has 1% mortality. Plasmodium falciparum causes 15% of the cases, and Plasmodium vivax causes 80% of the cases. Transmission is through the Anopheles female mosquito. Plasmodium exhibit schizogeny, which is asexual reproduction in humans. They have multiple nuclear divisions, followed by the envelopment of nuclei, which are schizonts, by the cell walls forming merozoites. The merozoites then take the extracellular blood and ring form. The trophozoites are the intra-erythrocyte form, and the schizonts are the products of schizogeny, which is where the red cell is full of merozoites. Gametocytes into mosquito then fuse and they form the zygote, or the ookinete. The sporozoites are products of the sexual phase in the mosquito and are the form transmitted to humans. That's a lot to remember. You can summarize it here in this figure, which talks about the Plasmodium simplified life cycle. We have a red blood cell, where we have a merozoite schizont and the trophozoite, or ring forms. Then you form gametocytes, which can go into the mosquito when they suck our blood. The gametocyte transfers to the ookinete and then to the sporozoite, which is then injected into our bloodstream when they bite us. Sporozoites goes to the liver, forms merozoites. The merozoites go to the blood, and they go to the red blood cell. This is a little bit more detail than you'll be asked on Step 1, but it's important to know that you can cycle from the mosquito to the blood, to the liver, to the blood, back to the mosquito. Pathology for Plasmodium is often paroxysmal, or it has a sudden onset and sudden stop of fever due to large numbers of red blood cells rupturing when the merozoites come out, or the schizonts come out. Plasmodium falciparum is the most dangerous form of malaria. It infects the red blood cells of all ages, unlike vivax or ovale. It's rapidly fulminating, and you can have irregular fever cycles of 36 to 48 hours, or you can have a continuous fever cycle. It's a common cause of cerebral malaria and blackwater fever. And you also get banana gametocytes on the peripheral blood smear. Plasmodium vivax and ovale have a tertian fever cycle, or every 2 days, and Plasmodium malaria has a quartan, or every 3-day fever cycle. The fevers correspond to released merozoites. That stimulates an immune response and gives you fevers, chills, and sweats. So if you have a patient who comes from Africa or another endemic area, and they're having every day or every 2 or 3-day fevers with chills and night sweats, you'll want to think about Plasmodium and malaria. This next figure shows the clinical microscopy of each of the different forms. You can see ovale has a little oval, falciparum has a double ring shape, vivax has its unusual form, and malaria also is characteristic. Falciparum is fearsome because it infects all the erythrocytes at once, as we talked about, and they can get paroxysms every day. As we talked about before, vivax and ovale usually attack the young and have every 48-hour paroxysms, whereas the mature malaria is only in the old cells, and they get paroxysms every 3 days. Vivax and ovale get hypnotized, or they form hypnozoites by the liver and must be treated with primaquine. Interestingly, for malaria, sickle cell disease, sickle cell trait, and thalassemia are resistant to malaria. There's a difference in their red blood cells, and so they don't get infected with the parasites, and so they don't have the disease. Also, the Duffy null blood antigen protects against Plasmodium vivax. So this is a unique twist on an otherwise sad disease. People in sub-Saharan Africa with sickle cell disease are not at risk for developing malaria. Treatments for malaria depend on what you want to treat. If you want to treat the schizonts, you have to get schizonticides, like chloroquine, quinine, mefloquine, or pyrimethamine. Primaquine is for the extra-erythrocytic form, and resistance in Vivax and falciparum is common. Fortunately, Ovale and Malariae do not have resistance to the schizonticides. You could try artemisinin, which reacts with heme and kills the malaria as well, or you could do ciprofloxacin, folic acid antagonists, and others. In short, there's lots of different treatments for malaria because none of them are very great. Prophylaxis for malaria includes chloroquine. If chloroquine resistance is a problem, then you have to do mefloquine or doxycycline. Primaquine is the prime drug to kill Plasmodium vivax and Plasmodium ovale in the liver. You give it with chloroquine. Again, chloroquine resistance is an issue, and so you have to think about mefloquine or quinine plus pyrimethamine are the preferred agents. If you have cerebral malaria with falciparum, you have to do IV or IM quinine, or artemether, which is effective against chloroquine-resistant Plasmodium falciparum. If you have glucose 6-phosphate deficiency, then you cannot give primaquine, chloroquine, or quinine because you'll get hemolysis and then you'll be in trouble for a different reason. In pregnancy, you'll want to give chloroquine or quinine, but not primaquine, mefloquine, or doxycycline. Question. A 31-year-old news correspondent on his return from Africa complains of tiredness, sore muscles, spiking fevers, and then he gets a disabling illness complicated by anemia, pulmonary edema, renal failure, and shock. Which of the following organisms is the most likely pathogen? Well, as we talked about before, this looks a whole lot like malaria, and so we want to talk about malaria falciparum, which is the fierce or fearsome one. It's more common, and it's the one that's going to have the frequent fevers, and it's more likely to be widespread and cause disseminated infection. Toxoplasma gondii is the causative agent in toxoplasmosis. It's a worldwide disease, which is different from some of the other parasitic infections we've talked about. Also, it can infect all vertebrates. The definitive host is the cat, and unfortunately, the accidental host is the human. We get it by ingesting oocysts from undercooked meat, cat feces, or transplacentally, or from blood transfusions. We can get infections which are often asymptomatic. Most people have antibodies to toxoplasma without even knowing they were ever ill. If you get it congenitally, you're going to get hydrocephalus, it's increased incidence of stillbirth, you can have brain lesions and blindness. If you're immunocompromised, you're going to have severe cerebral infections with recrudescence. Toxoplasma is a classic disease you're going to get in an AIDS patient, and they're going to have a ring-enhancing lesion on CT scan. With toxoplasmosis, you have tachyzoites, which are rapidly growing trophozoites, and these are in the body fluids during acute infection, and they directly destroy tissues. You can also have bradyzoites, which are slow-growing trophozoites, and these insist in the muscle, brain, and eye, and can stay there for years and years. If you rupture the tissue cyst, you'll get inflammation, thrombosis, necrosis, and badness. So if you've got a tissue cyst, unless it's causing a problem, you want to leave it alone. The diagnosis is by serology, radiology, and biopsy. Treatment is pyrimethamine and sulfadiazine. Trypanosoma brucei is the causative agent in African sleeping sickness. We get it when we're bitten by the tsetse fly. We get a fly bite that turns into a chancre, and then we get extracellular replication cycle in the blood and the lymph. Unfortunately, it invades into our CNS, where we get inflammation, lethargy, coma, and death. The diagnosis is based on clinical exam, serology, and biopsy. If you can visualize the trypomastogotes in the peripheral blood, you've got a diagnosis. You could also look in the lymph nodes or spinal fluid. If you catch it early, you can treat it with suramin and pentamidine, whereas if you get it late and it's already in the CNS, you have to give melarsoprol. Trypanosoma cruzi is the causative agent in Chagas disease. Transmission is through the reduvaid bug. The bug bites us, and we get infected through its feces. It invades into us, into the cardiac myocytes, into the nervous plexi of the esophagus and colon. You get a shigoma, which is swelling at the bite site. Chagas disease causes myocarditis and a dilated cardiomyopathy. It also causes megaesophagus, leading to ankylasia. You can get megacolon as well. The diagnosis is based on serology and biopsy, and you try to visualize the trypomastogotes in blood or the amastogotes in tissues. You treat it with nifurtimox. Here's a clinical picture of Trypanosoma brucei and cruzi. You can see here the reduva bug on the bottom right is this big, ugly thing that we get it from its feces after it bites us. A 14-year-old Brazilian immigrant girl presented with shortness of breath and palpitations. EKG shows alterations in heart rhythm, and echocardiography reveals biventricular dilatation with massive cardiac enlargement. EMG biopsy shows diffuse interstitial fibrosis, myocyte necrosis, chronic inflammation, and the presence of an intracellular protozoan parasite. The most likely diagnosis is... This question is fortunate because there's only one parasite that's going to cause a dilated cardiomyopathy, and you're going to see it with inflammation inside the myocyte cells. That's going to be Chagas disease. You get it from the reduva bug. It's T. cruzi. Before, when we didn't know that it was parasitic, it could have been a whole lot of other things. But once they tell us it's a protozoan parasite causing dilated cardiomyopathy, it's Chagas disease. A. During a visit to Nigeria, an electrical engineer was bitten by the tsetse fly. He developed a chancre at the site of the bite, followed by generalized lymphadenopathy progressing to lethargy, apathy, mental depression. Examine the lymph node reveals curved motile organisms with a free flagellum. The most likely organism is Trypanosoma brucei. This is, again, we have African sleeping sickness, and we have a tsetse fly. Treatment of the central nervous system manifestations of African sleeping sickness involves administration of which of the following agents? Like I talked about before, Melarsoprol is what you use for CNS African sleeping sickness. Leishmaniasis infects about 12 million people worldwide. It's transmitted by the sandfly and comes in three different forms. Cutaneous leishmaniasis, which is the oriental sore, commonly caused by Leishmaniasis tropica and mexicana. Mucocutaneous leishmaniasis, which is caused by Leishmaniasis brasiliensis, and visceral leishmaniasis, which is also called Kala-Azar, which is the form of massive hepatosplenomegaly and can be fatal, and this is Leishmaniasis donovani. The diagnosis is through serology and biopsy, and you have to demonstrate the protozoa in peripheral blood. You treat it with stibogluconate. This is a simplified life cycle for Leishmaniasis. We have the sandfly, which has the promastigotes, which are flagellated, and then it bites us, and we get amastigotes going into our macrophages. Amastigotes go into our body, look like this with all these little starry sky appearance, and cause disease, and also get picked up by the sandfly when it bites us again. Let's wrap up Module 45. We had a summary slide where we talked about intestinal and urologic protozoa. That'll help you summarize them and be familiar with the different agents. Then we talked about blood and tissue protozoa. We talked a lot about malaria. It's a common cause of death in sub-Saharan Africa. You kind of wish you had sickle cell traits so that you could be immune from it. You should be familiar with the 4 different Plasmodium species, which ones are most virulent, what they look like on a peripheral blood smear, and how frequently they induce fever cycles. You should be familiar with the treatment, and also just recognize that resistance to Plasmodium to antiprotozoals is common, and we need to worry about that. Next, we talked about toxocariasis, trypanosomas, and leishmaniasis. These are characteristic diseases. Often they'll give you enough clues in the question stem to know what it is, as long as you're familiar with what they do, where you get them, and how they affect our bodies. Knowing the treatment is also important. In Module 46, we're going to talk about helminths, and we'll have a summary slide for the blood and tissue protozoa.